I welcome you all for the 8th Creative Theory Colloquium 2021. The title for this year's colloquium was COVID-19 Pandemic, Grassroots Experiences and Democratic Responses. The colloquium was organized by Foundation for Creative Social Research.
The number of health organizations and science movement in India as senior advisor of Sathi Chehat, a leading NGO in people's health movement in India. The third speaker is Ritu Priya. Dr. Ritu Priya is a medical graduate with a doctorate in community health. She is professor at the Center of Social Medicine and Amputation, Community Health, Jawaharlal Nehru University. The discussant for the session is Sayan Das, who is a medical graduate currently pursuing his PhD in public health from Center of Social Medicine and Community Health, Jawaharlal Nehru University, New Delhi. The rapporteur for the session will be Sanghamitra Dev Roy. I would now like to request the chair to take over and begin the session. Thank you.
Hello everyone, good morning and welcome to the second session in the second day of this webinar. I should congratulate Foundation for Creative Social Research for their unflinching and amazing regularity with which they have sustained these annual events, which are fodder for thought and discussion. I had the occasion to participate in some of them. So whether pandemic or not, the sessions have been going on every year. And every time we get new ideas from young people, freshers, as well as senior people coming up with their latest works. So it's an absolute delight for any scholar. To this year's session on the democratic responses to the pandemic, you already know many dimensions have been explored. This second session is on COVID crisis and the crisis of public health. Which I'm sure is the much needed session of the hour. But as someone who's been watching and pursuing the developments and data, I noted two things about the way this COVID public health crisis has been fielded. On the one hand, we find that there is an explosion of data on COVID in the public domain, and terms like case fatality, reproduction rate, etc., which are being spoken by journalists, and they have become part of our normal conversation, common parlance. I'm sure everybody, I've heard, gardeners, maids, etc., also talking about CFR, referring to these rates and so on and so forth. So there is a explosion of information, one, which all of us have been encountering. And the second aspect that I notice is that, contrary to earlier kind of binaries between science and its others, we have now multiple perspectives from different sciences. If you look at, we have not just biostatisticians, there are mathematicians proposing models. They are predicting the death rate, etc., based on abstract mathematical models. You have virologists, and then you have the genetists who are talking about the strain, mutant, etc. And then you have epidemiologists whose data is based on actual incidence and prevalence rates. And then you have journalists drawing on these various things. And then you have the more grounded disciplines like geography, public health, and the social sciences that are collecting data based on face-to-face or interactions, or which are gathering data, real data on the ground situation. So you have many sciences. What I encounter in this whole discussion is that many sciences are there. It's not science versus something else. And they are fielding different perspectives. And this is extremely critical to understand the nature of the crisis. In the Surat plague of 1994, Kavita Shivaram-Krishnan, the historian, notes that the way the virologist appointed by the central government designated it as the plague, whereas the bacteriologists, and whereas the public health experts and social scientists who were on the ground they thought, expressed doubt as to whether it should be designated as a plague or not, and so on. So, depending on the constitution of expert committees, the understanding of the problem could also change. I mean, if mathematicians had not projected these models, the draconian lockdown may have not, may have not been necessary. So, in this explosion of information and the polyphony of experts, we need to have a perspective. We need how to bring this data together. What perspective do we need to take? And I do sincerely hope that this session, where we have experts in public health, Professor Ritu, Priya is there, and Dr. Anant Phadke, and a researcher in political science. So I'm really looking forward to a perspective where these many expert voices coming on the pandemic and the extent of the crisis it projects. On the one hand, the state is denying there was any oxygen related deaths. So we also know that data creates its own magic. It can be manipulated. It can, and in this post-truth society, how do we develop a perspective? How do we assess the extent of the crisis? And here we have these experts to listen to whom I'm as eager as you. So who will, in the sequence, who is the first to talk? Priyanka, will that be you? Yes. So I think it's a 2-hour session, and the speakers, individual speakers, could take something like 20 to 25 minutes, and the discussant can take about 10 to 12 minutes, and we'll have enough time for a discussion. This should be fine. Yes, Priyanka, please start.
Thank you so much, Chair. Thank you so much for inviting me, introducing me to the session. And I thank Creative Theory Colloquium for giving, and Foundation for Creative Social Research for giving me this opportunity to present my ongoing work, which is also a part of my PhD thesis. So I don't think I'll take too much of time. 20-25 minutes is actually more for me. I'll rather try to wrap it up in lesser amount of time. And without making any further delay, I think I would start. So the pandemic, especially the second wave, gave enough instances to think and realize why health, be it individual or communities, is important. What is the nature of health? Who should it be? How should it be maintained? Who is responsible for preserving it? These are questions which have intensified with the pandemic. Very recently, Professor Manoj Kumar Jha, Member of Parliament, raised a crucial question. Why do we as a country and government do not talk about right to health? In fact, he went ahead to demand right to health under the right to life, which is a fundamental right guaranteed under Article 21, right to life. What is bringing political attention to the subject of health? Of course, the pandemic and the widespread virus. Moreover, it is the nature in which the subject of health has been exploited during the pandemic. Deaths due to the non-availability of hospital beds, lack of primary care, and the crisis of public health during a health emergency has brought these questions to fore. While talking about state and institutional handling of the crisis, the worst problem among all other odds was the oxygen crisis, or the non-availability of liquefied medical oxygen during the second wave of COVID-19. Oxygen, the prime compound of human life, was bought, sold, hoarded, and even black marketed during the COVID-19, second wave of COVID-19 crisis. Liquefied medical oxygen is otherwise used during medical procedures and medical emergencies. However, in the second wave, the COVID-19 virus directly affected the respiratory system of the host, causing problem of respiration and sudden drop in oxygen level, further weakening the immune system. Since the cases were increasing steeply, the demand for LMO also increased. Before the crisis, India was a producer and exporter of liquefied medical oxygen. However, when the crisis hit in April 2021, to meet the sudden rise in demand, Ministry of Health and Family Welfare planned to import 50,000 metric ton of liquefied medical oxygen. The irregularities and sudden surge in demand led to nearly 35,000 deaths. However, this number is not appropriate, as the data of deaths due to oxygen shortage was neither recorded nor made available. Indeed, the crisis was unforeseen, which not only strained the health system but also administrators, policymakers, and diplomats. Time and again, judicial activism was witnessed where Supreme Court had to intervene and take matters in hand. There was a headline in the newspaper which read that beg, borrow, steal. It is a national emergency. This was the remark made by the Supreme Court. As much as the pandemic was responsible for the crisis, to a certain extent, it was the amalgamation of neglect, ignorance, and politics of the government at both the central and state level. For instance, transportation was a major cause for this intensification of liquid LMO oxygen crisis. I'll just explain this a little bit. The process of extracting liquefied medical oxygen to delivering it to hospitals or health facilities is a technical process, which is meticulous. To begin with, manufacturers prepare oxygens through cryogenic distillation technique, which is then stored in jumbo tankers and then transported in cryogenic tankers at a specific temperature to distributors in both urban and remote areas. These distributors then compress oxygen from liquefied medical oxygens and store it into cylinders or dura cylinders, which are supplied to hospitals directly or to a third-party agent. The process of extraction sounds technical, but was not a hindrance in meeting the demand of oxygen. But transportation was the major cause. India lacks cryogenic tankers required for the transport of LMOs. Moreover, there remains a shortage of cylinders and tankers in which LMOs are filled. Transporting LMO through cryogenic tankers to distributors, especially to remote locations, is time consuming, which might at maximum take 5 to 10 days. If the location is too remote, it can take too long. Small hospitals and distributors are vulnerable and least preferred, as they often complain of not having enough cylinders and tankers for LMOs. Another problem that was faced here, which intensified the oxygen crisis, was delay in cross-border movements. So the large part of LMO production is based in East and West India from states including Maharashtra, Gujarat, Jharkhand, Odisha, Tamil Nadu, Karnataka, Kerala, and West Bengal. However, the surge in demand for LMO came majorly from North India. This involved transportation of LMO in huge amount. And here is where a hue and cry about transportation being stopped at state borders was recorded. In Delhi, for instance, MLAs and MPs blamed neighboring states like Haryana and UP for not allowing tankers to enter Delhi. The capital, with no manufacturing unit in its region, depended completely on imports of LMOs from other states. A statement given by Delhi's Deputy Chief Minister Manish Sisodia noted that the shortage of LMO in Delhi hospitals was due to the monopoly of Haryana government that directed the supply of LMO from Delhi to Haryana. And so these were the reasons, which short-term reasons, which intensified the oxygen crisis. However, apart from this, a rather big issue, or rather a pertinent question, was that health was not. This also came to fore because health is not recognized as a fundamental right. You may find the mentioning of a right to health or the subject of health in the directive principles of state policy. It is also in the state list, but it is not fundamental. It is not recognized as primary. Apart from being in originality, it being very important for sustenance of humans. Although Supreme Court of India at several occasions have interpreted right to health as primary under Article 21 of Right to Life. However, directive principles of state policy and interventions made by the Supreme Court have been non-binding and further non-justifiable, which makes questioning and demand for health facility as a right and duty of the state very weak. This constitutional legality and liberalization of the economy further turned a basic right into a commodity, a thing of value that can be now bought and sold in the market. So now this brings us to the debate of the neoliberal time. What is then health? A right or a commodity? And if it is a right, why should it be a right? Who is responsible to deliver it? And how do we accommodate heterogeneity in nations and in demand? So the stances here are very divided on the question of right to health. So there are two stances. One are the paternalists who say that healthcare is a right and should be provided by the state. On the other hand, there are liberals who say that healthcare is like any other commodity and should be treated as any other economic good and services, and therefore should be left to the market. The entire debate over the right to health streams between whose duty is it to fulfill the healthcare needs in society. Is it an individual duty, or the state responsibility, or whether the market responsibility? This debate therefore requires a precise lens to be comprehended with necessary conclusions. Therefore, I propose to understand the debate of right to health. I propose to understand the demand for right to health from the Rawlsian perspective. So, John Rawls talks about the theory of justice in a well-ordered society, where he introduces the idea of primary good, a good, or as Rawls terms it, claims are personal, political, social, and economic demanded by individuals respectively. Out of the many claims that Rawls has introduced, which are intrinsic to mankind, one of the important claims is the social basis of self-respect. Now, this claim is important because this principle of social basis of self-respect is important because it links it to right to health, as right to health is a major constituent of individual self-respect. In a well-ordered society, self-respect is the catalyst, the motivation behind individuals' strive for primary and higher good. Without self-respect, she can never reach the height of their potential. Self-respect is sought, sometimes through individual action and by the action of the other. In the former case, individual act of achievement, hard work, fame, or other social conditions brings that self-respect. And in the later case, recognition by others, like state or its constituent, brings that recognition. David de Grazia, amongst other social conditions, mentions that the vital condition that significantly affects esteem and self-respect are bigotry, unemployment, access to decent education, and lack of access to healthcare. It is to be noted here that access to healthcare is substantial in aiding the higher goals of employment, health, and finally self-respect. Rawls' quest is to make the necessary preconditions for achieving primary goods available. How to achieve it, what measures are to be adopted to achieve the same, or how well does the good serves its purpose is not the Rawlsian concern. It is here where Amartya Sen's capability approach becomes important. As Amartya Sen has answers to the problem of utilization of primary goods and how well are the principles implemented. Capability approach proposed by Sen is a two-dimensional approach, which unlike the Rawlsian framework is concerned beyond the accumulation or acquisition of good. Sen begins with the thought that every individual desires for functions which are of two types, lower and higher. where the former includes functions like cooking, driving, typing, cleaning, and other day-to-day activities. The latter functions include functions of higher purpose, like becoming something, achieving or accomplishing a desired goal, or for instance, tapping his or her potential to become a renowned personality. The lower set of functionings are not desirable or pleasurable goals. Nonetheless, the higher functioning is intrinsic and involves emotion and desires of achievement. Higher functioning involves capabilities or capacity to perform tasks directed towards a goal with necessary skill. It is important for these capabilities to become functioning to live a life with purpose. Here is where state becomes important medium which can bridge the gap between capabilities and goals. As sometimes individual might have the freedom or realization about their capabilities, but lack the means to utilize their potential in this case. And in this case, the goal remains unachieved. So Sain, unlike Rawls, is not only concerned with the availability of good, but also the capability of the individual in transforming it into functioning with the help of the state and its constituent units. If this framework is applied in the right to health debate, then right to health is justified in achieving the desired functioning of the individual. Assume a person wants to cure his ailment for the achievement of his lower and higher functioning and cannot because of lack access to affordable healthcare. In this case, he is denied of his basic liberty or basic right. Thus, it is vital to protect that liberty and right of the person, and state institutions are responsible in doing the same. Saints Sain entitles the state with this responsibility. Rawls gave the answer of what is right to health, that is a primary good. Sain helped in understanding who is entitled to ensure right to health, that is the state. And however, one question remains: how will the state ensure right to health? What model should be adopted to assure discrimination is avoided at the least? Since right to health is a broad terminology and particulars of these rights are not defined, it is difficult to comprehend what accounts to right to health. Two people availing the right to health will have different notions about the same. For one, it would equate to primary health. For the other, it can be free medicine. In this case, then how is it possible to achieve the goal of right to health? Surprisingly, the answer to this question lies in the field of law, in the theory of incompletely theorized agreement as formulated by Sustin in 1995, who developed this theory to understand certain judgments made by principal stakeholders where they agreed for a broad principle without getting into the particularities of the same. So, incompletely theorized agreements are a part of democracy where heterogeneous population, where individual and policymakers have different opinion on the same issue. In this case, an incompletely theorized agreement suits public policy as it arrives at a general principle without formulating the particulars of the principle. In conclusion, I would say incompletely theorized agreement provide a framework to the right to health debate where the question of what constitutes right to health forever remains. Following Sustain's framework, then it is important for policymakers to first accommodate the general claim of right to health, leaving behind disagreements on the particulars of the claim. This way, a general theory can be obtained which will suit heterogeneity and diversity. So thank you so much. Thank you.
Dr. Anant Phadke, he's, as you all know, he's been associated with the Medico Friends Circle, and I'm sure, as a medical doctor, as someone who's been deeply invested in the political economy of health and medicine, he will be enlightening us on how to address the crisis, what constitutes the crisis, and what are the different dimensions of it. Dr. Anant Phadke.
Thank you. Thank you to the organizers for inviting me here to participate in this webinar. To begin with, I would like to make some clarifications about the terminology to be used. Because in the concept note and as well as in the earlier presentation, I felt that at least it was not clear to me what is meant by health. See, in conventional terms, we understand health has three components. One is health status. I'm just sticking to basics before I go to my presentation. And which basically means your life expectancy, maternal mortality rate, infant mortality rate, age-specific morbidity and mortality rates, etc., including psychological health. That is health status. So when we say health, what do we mean by it? Health status, or we talk about health, social determinants of health. And we know traditionally nutrition, sanitation, pollution, etc., are considered from school days as social determinants of health, quite rightly so. But now in modern world, we have, like in Jan Swasthya Abhiyan, we have identified something like 20 social determinants of health in India, about which we have made certain demands to the government. So all the social determinants of health are the ones which actually determine basically your health status. And health services have only a minor role to play. And thirdly, so when we say right to health, basically it means that right to social determinants of health in a sense. And also it also means right to health care, which has relatively, fortunately, smaller part to play in maintaining the health status of population. I think these are very basic things. So what I'm going to talk now, coming 20 minutes or so, is just restrict myself to health care and not about social determinants, not about health status of the population. This is something which I will not be able to discuss given the lack of time. Secondly, I will restrict myself only to overall framework of public health services. The whole issue of oxygen fiasco, which Priyanka talked about, or the criminal vaccine failure, is something which I hope Dr. Ritu, Priya will take it up. So with this limited framework, let me start with telling you, sharing with you, since some of you, probably many of you don't specifically belong to the public health background in a narrowly understood term. Now, actually, everybody should be concerned about public health. But basically, we all know, many of us know, that the Indian public health system, we have inherited a very dismal scenario actually, which has developed over the last 70 years. Initially, of course, after independence, there was some very clear improvement, but later on things stagnated, and now last 40 years it has deteriorated. One of the indicators is that there is a very low investment by the government in public health, which is 1.3% of GDP compared to what all of us know, the WHO recommendation of 5%. Now, as a result, just to take very broad indicators, if you see the basic availability of healthcare services in India, we find that WHO has recommended 1 doctor per 1,000 population. India is 0.7. These 0.7 doctors, half of them are non-allopathic doctors who routinely do allopathic practice. So the quality we are not getting into. But in terms of quantity, urban rural together, it is 0.7%. If you divide into urban rural, there is absolutely gross inequality across urban rural, across social sectors. The socially vulnerable people, whether it is Muslim, Dalit, women, etc., all kinds of social, they are basically, the accessibility to doctors is very low. I'm not going to do all the details. If you take overall gross figure, 3 nurses per 1,000 population recommended, we have only 1.5. 3 hospitals bed recommended, we have only 0.6, which is 1/5 of what is required. And therefore, there is no wonder that we have a big, huge crisis during COVID period, because COVID period, our hospital capacity all over the world was stretched to its limits. Now, what kind of healthcare is there? If you see that in public health, I will come to private healthcare if there is time permits. Take Indian rural health statistics 2019. Only 10% of the PHCs fulfilled Indian public health standards. 25% of PHC doctors' posts were vacant, and more than 60% of specialist posts were vacant. Even this area like Maharashtra, which is supposed to be developed, from which I come, the situation is absolutely dismal. Now, if you come to medicines, which is an important but small part of healthcare, if you see what is the per capita government expenditure on medicines, it is just 100 rupees, not even 100 actually. Whereas in citizens, you and me together, urban, rural, rich, poor together spend something like 900 rupees per capita, 9 times as much. So we have one of the most privatized and one of the most unregulated healthcare systems in the world. Okay, so this is the overall background. And there is a second thing which is probably not very much emphasized in many progressive circles. I do belong to progressive politics, but I do feel that all of us who stand for public health services and who are some kind of advocates of public health service should also take into account the very problematic nature of public health services after independence. Firstly, as you probably know, that we have all IS babus ruling over the medical system. Unlike you take forest department, police department, they have those specially trained officers. They have this Indian Forest Service, they have the Indian Police Service where they are trained. And at the highest level, these are the officers who are trained in their particular discipline who basically lead. Now, how do they lead? What they do? What is their relationship politically is a separate issue, but at least basically they have some basic knowledge about this, about the department they have to rule. Whereas in our healthcare system, yesterday somebody was an income tax secretary income tax, today becomes secretary health, and he tells orders around the highest public health officials in various states. Now this is absolutely abysmal. Dr. D. Banerjee and others have consistently pointed this out, that we should have the Indian medical service as it was at the beginning of the independence, but that was never reverted to. Secondly, we have probably some of you may not know this from close quarters. We have a command and obey system from Mantralaya to PHC. It's absolutely hierarchical because it all started with military-like operations in smallpox eradication, malaria eradication, plague, etc., etc. All that, and of course the colonial heritage. All this has continued, unfortunately, and that has really affected greatly all our healthcare services, especially in COVID period also. And there is absolutely no accountability whatsoever. The PHC doctor cannot say a word in a meeting at the state level meetings. It is down everywhere. Even the PHC doctor just howls at the nurses, and there is absolutely no accountability. And the community at large has nothing to say except their political leaders. But as an ordinary citizen and an ordinary person has absolutely no stake in the public health system in India. And therefore, the highest people at the public health system, the people in Mantralaya who take decisions, who give all kinds of fatwas, orders, many of them, they have absolutely no connection with the actual what is happening in the ground reality. So this is the kind of overall framework. And now last 40 years, we have the disease of contractual employment, temporary employment, vehicle posts, all this has come out of privatization, very clearly linked to privatization. Now, this is the kind of public health system which is malnourished, which is demoralized, which is not very functional only on command, which is what we started with when we had COVID, which is the largest challenge that we faced after independence. Now, there are two major tasks that were there for the public health system. Basically, the basic function is controlling the spread of the epidemic, and there are some very well-known principles of epidemic control. They were not followed because nobody believes in the public health experts in India. All the task forces and all the experts who advise the government or Niti Aayog, if at all they listen to any advice, is basically by clinicians or renowned clinicians who are excellent in their own way, world-class clinicians, but who some of them are excellent in public health also. But the public health experts who have been trained and who have been working and who have been teaching public health, they were nowhere in the picture. So the first major blunder from the point of public health that was considered was this lockdown, which was total comprehensive national lockdown. I think a lot of discussion has taken. As a public health person, we would say that yes, lockdowns or this kind of have a role to play, provided they have based on certain well-defined parameters, and there are certain rules and some guidelines about what to extend, when to impose restrictions, when to remove. All that was absolutely not clear. We never knew what kind of parameters were used, what was the evidence based on which decisions were made. All this is a matter of secrecy, and therefore ordinary people suffered. The basic things like provision of subsistence support for poor during lockdown. You don't have to be a public health person to know. You have to be just sensitive human being, but that was not done. And as we know, everybody talks about poor people, migrant workers being starved, people who have come to the cities, they have no families, they basically eat outside. All their food is from outside eateries. They more or less starved, had to starve because nothing was available. Even if you have money in their pocket, if at all, you didn't have anything to eat. So these kinds of unnecessary restrictions, of absolutely insensitive restrictions, have really affected public health, the health of the state, health of people. Yes, one thing is good that scientific guidelines were prepared by ICMR about testing, tracing, quarantine. They're all internationally well-known guidelines which were probably honed for some of the Indian conditions. And however, because of lack of facilities and infrastructural thing, actual testing facilities were very less initially and even now also. And therefore, if you see the number of tests done per million population, we can boast about so many crores of tests being done, but if you reduce it to the test per million, India scores very low. And that part of the testing was absolutely pointless. It was not focused. But in Kerala, they really did justice to public health science. They focused on symptomatics to begin with and their tracing, all their contacts, and therefore the yield was much higher. And therefore, in Kerala, number one, their test per million was also high, and they're far more productive, far more efficient way of testing things, which is basically following public health. And there are, of course, phases of the epidemic where you do for target testing in a certain period, initial period. Later on, you go for a much broader based testing. I'm not saying you only keep testing the SARI people, like the symptomatic people, but all those basic elementary science of public health epidemiology were totally overlooked. And all kinds of decisions came from above. One of the reasons, gross reasons, was acute shortage of staff. As I just saw a little earlier that the staff is not even half. Nurses or even paramedic staff is absolutely, in terms of numbers, in terms of quality also, in terms of training, motivation, is so low that you can't expect such people to work wonders when the time really comes. But to their credit, under command, under threats, they really functioned to the full extent. All of them overworked themselves. All of them had to risk their health because the PPAs were not available for all the contractual staff, etc., etc. And one more important reason I would like to emphasize this particular point, because that is an Indian reality or maybe developing country reality, that in standard public health, we say home quarantine. But the home quarantine is possible only in places we have a home of 4 or 5 rooms. And the average population family size in the West is about 2-3 people, whereas in India at least minimum 5. And the average home size is 2 rooms. So it is almost impossible to follow home quarantine in most Indian families. And unfortunately, because this was not recognized or ignored conveniently, and therefore the home quarantine was the main modality of putting you into your homes and locking you up, without giving you food, when you are transmitting your infection to your fellow people, because a large part of the infections are asymptomatic. So the point is, most people did not want to. There are very few COVID centers, quarantine centers run by the government, because they don't have a good reputation. There is no good food, there is no good care, elementary medical facilities are lacking, etc., etc. Some of them are excellent, except in Kerala. And therefore, most people did not want to go to government quarantine centers, most of which are very far away, and therefore they are not accessible to people. There are, of course, a lot of rumors about it, wrong kind of rumors. But on the whole, one could say that home quarantine was one of the important reasons. That is my argument. Some people may not agree with it. Is one of the ways in which actually this epidemic spread silently at home. And given the low test rate, so we have so many asymptomatic and mildly symptomatic infections, so many mild cases who did not dare to go for testing, who remained at home because they felt there is a stigma around. All this together, we saw a silent spread within homes despite this draconian lockdown. Now coming to management of severe cases, two functions. And you see, infection is no problem. The more the infection, actually you spontaneously reach towards the stage of herd immunity. And I am, despite some limitations, I am one of those followers of Professor J.P. Mulial, who has been telling us, don't be bothered about infection as such. Please be concentrate your attention on the vulnerable population and the severe cases. That is proper public health epidemic control. Okay, and therefore it is not those numbers, huge numbers, so many people infected. It is the number of patients, and the patients become those who become severe patients. And the key to preventing deaths or reducing deaths, you can't prevent all deaths, is basically to identify a mildly symptomatic patient when that person is getting severe COVID-19. And the whole attention has to be focused on that. For that, you have to monitor that person on a very simple parameters or clinical parameters and simple oxygen oximeter. You don't require blood test so much. And therefore, it is eminently possible that you get all positive people into a quarantine, a good quality quarantine, which doesn't cost a huge amount of money. Monitor them properly with simple paramedics or even volunteers. And those 10% or 15% who start getting into complications, detect them on day 6 or 7 and start simple oral steroids immediately in second week, not in first week. And that will reduce considerably the hospitalization rate. This has been done in many parts of the world. In India, also many doctors have done it. Unfortunately, of course, there is no double-blind clinical trial which can validate this hypothesis. So I concede that this particular thing that thing is actually well tried in many what we call anecdotal experiences. But if the government could have taken up a good double-blind clinical trial to find out what happens. Anyway, many doctors have been doing this informally. Even the guidelines are also somewhat open about it. And a second week timely course of steroids will save a lot of hospitalizations and a lot of deaths. Now, this simple thing was not available in India most places, and therefore the death rate was very high. But I should say that, as I said, I will not, yeah. So this was not done by ICMR. The guidelines were very general, very vague. Of course, there was not adequate evidence, but I do feel that in exceptional times, certain exceptional measures should have been taken, and something should have been talked about as a second week steroid based on clinical parameters. And this was not done, and therefore many patients ended up in hospitals very late, and the high mortality is proportional to number one, the morbidity, your baseline vulnerability, and also proportional to when you access medical care. And since medical care was generally not available in the public health service, I'll come to that a little later, and very costly and exploitative in public sector, private sector. Therefore, ordinary people were actually more or less deprived from adequate public medical care, and therefore a lot of people died unnecessarily. Okay. Positive thing about public health services that no doctor abstained from duty. They were ordered to be around, and they did all the paramedic staff did an excellent job. One of the consultants, I stay in Pune, which is near Mumbai. Mumbai KM Hospital and Sayan Hospital, the best, one of the best in the world at India level also, and they did a fantastic job. So it's a myth to say public hospital में कुछ होता नहीं है. There are the tradition in some of the hospitals has been to give excellent care, not the 5-star all India IIMS type care, but good quality clinicians and good staff can together really pull up the shoe. And that was certainly done in many public hospitals. Some of them I've seen from closer quarters from Pune. So overall, what I would say that given these basic constraints of the public health system, it is malnourished, it is hierarchical, it is demoralized, it has no adequate supplies. All this means a higher mortality rate. Okay, and in Kerala, where these things were somewhat taken care of by the government, the case fatality rate was 0.5%, whereas in Maharashtra, which is supposed to be a developed state in other rounds, was 2.1%, which is 4 times. So I think all this was necessary in Maharashtra. Why so many people died in Maharashtra? Because of the basic problems of the inadequacy of the public health system. I think I have almost finished my 20 minutes. So this is some recent statistics. It's not a It's a convenient sample, Janarogya Abhiyan, which is a part of Janaswastha Abhiyan. Wherever activists are located in Maharashtra, they did a short survey, and I will not go into detail. Basically, it shows absolutely pathetic conditions of the primary health centers, of the rural hospitals, and all centers below district, because all government medical colleges were attached to hospitals. Those medical college attached hospitals were doing all right, but below that there is absolute poverty of everything, from expertise to supplies, and therefore the death rate in Maharashtra continue to be high, except the metropolitan cities like Mumbai, Pune, etc., etc. This is the so I just this particular slide can be shared, and do want to know the details can have it. And lastly, just in a couple of minutes, I would just say that the private health sector, which accounts for 80% of the healthcare in India, were abysmally failed, predictably, because firstly, what was somewhat unpredictable was most doctors, small clinicians, small clinics and hospitals just stopped. They were actually, everybody was very much fearful. Part of it was because of plain and simple ignorance, and of course no sense of social responsibility. I don't think it's only doctors. Every section of the society, from teachers to lawyers to doctors, are grossly deficient in social. There are of course some exceptions. So lack of social responsibility was also an important factor, and therefore they just hid, plain and simple. The larger hospitals saw this as a money making opportunity. Their doctors who are on a salary, they had no other go but to earn money and also listen to the management. And some of them did an excellent job. In terms of clinical care, I can say that some of the even private hospitals did a very good job. I can tell you some of the trust hospitals, even some of the private hospitals, because we have some excellent world-class clinicians. Only thing is they basically are subservient to the corporate sector, and so they treat the patient all right, but they also add some useless investigations and useless medicines so that the hospital also makes some money. Ultimately, the patient suffers. So basically, my last point is that patients had ordinary patients in India had nowhere to go. They could not pay. They became bankrupt. There was no place also because of lack of beds. But wherever the beds were there, most ordinary citizens could not afford the private health care. And below district level, there was no competent healthcare available. And therefore, my contention is that literally, when you say, what is this crisis about? Crisis is inability to function in a normal way, if you go by a definition of crisis. And thousands of people unnecessarily dying, millions of people unnecessarily suffering is an absolutely crisis situation, which is because of gross deficiency of health services in India to take up the challenge of public health services, to the check of COVID-19 epidemic. So this is my case in short. Thank you for listening patiently. If there are any questions or the other points of view, of course, that's welcome, but it's a matter of further discussion. Thank you very much.
Thanks very much, Dr. Anant Phadke. You are for a very highly focused, presentation, squarely focusing on the issues. Now, Professor Ritu, Priya, I invite you to make the presentation.
Thank you, Sujatha. I really think that Priyanka and Dr. Anant have set this for what we've all witnessed during the COVID pandemic in terms of the failure of right to health and healthcare that was due to people who needed it during the pandemic. She's talked about the oxygen fiasco, and he's referred to the failures of the private sector and the public sector in terms of what should have got delivered and so on. What I want to share really is a puzzle that I'm trying to solve in relation to the pandemic. And I put it in this way, that during a period when we are all facing and attempting to deal with a pandemic, which is the biggest public health crisis in the last 100 years. And we are all predicting from yesterday, we've been talking about it, how it's going to affect all of society in the post-COVID period, this public health crisis is dealt with by ignoring and putting aside the science of public health. In modern times, how do we put aside the very science which was meant to deal and created in response to epidemics and pandemics? Why did that happen? And how could it happen in a modern society with a strong state and governance is the puzzle that I'm really trying to solve. And I think this is the right forum. And I would like to thank the Foundation for Creative Social Research for giving me this opportunity to share this question and therefore do some shared thinking on it. And this is, comes also as a question because it's versus the claim made by the leaders in our ruling dispensation that the claim there was sacrificing of the economy for people's health. And this was a dichotomy created about economy versus health, and we choose people's health for the economy. And we've been hearing all about the economy yesterday and this morning. So how is it that we understand public health and dealing with public health crises? Just to sort of quickly get into how I'm talking about the science of public health is defining public health, not public versus private services, which is one way that's become very common as people understand it, or merely disease control programs, TB control, leprosy control, malaria control, or diabetes control as public health. Public health, as classically defined, is the science and art of improving health and maintaining health of populations as a collective enterprise and as a collective phenomenon. Therefore, it's different from, and it's always sort of defined and explained as different from medical care and medicine. And there's a constant tension between, is public health the one which designs all of medical care and health services in a society, in addition to what Dr. Anant clearly pointed out as the social determinants of health. And therefore, public health looks not only at medical care, but at the social determinants of health, at the various factors and processes that lead to good health and to disease, and at thereby designing ways of societally dealing with the problems of health that people face. Now, in doing that, in this crisis, the issues that have been raised up till now have been about the political economy of distribution and access of the resources of healthcare services, which brings in the public-private divide and the quality of public services and so on. Also, the politics of governance, the issue that Anant raised about the IAS officers being in charge and therefore even the experts of the medical system not really being there in the designing, shaping, and operationalization of the system. So I would like to sort of divide this frame of public health into the politics of access and the political economy that goes with it, the politics of governance and the political economy that goes with it, and the politics of knowledge. And what I'd like us to think about is the fact that this politics of access and politics of governance cannot be corrected unless we take seriously the politics of knowledge. And I'll try and explain why I'm saying so, because I see that as underlying much of what we see as long or limitations in the way COVID pandemic has been dealt with. We have to look at this in terms of the, it's sort of, I think in the time that I have, exemplifying it through 3 or 4 milestones across health systems development and the way public health has evolved in the country would be useful. But we would also need to have to keep in mind that there is a much larger global discourse which shapes a lot of what we do here. And there is a medical industrial complex which is global and national and local. And all of these operate and add to the pressures of what finally shapes up as public health. The path dependency that we see across the 70 years, finally one can actually see it fructified. And since many more of us are now looking at healthcare and health issues because of COVID, we can see the kind of end point of it. If I come to the vaccine hesitancy, that's the other end of the public health spectrum. What is the people's response to it? And vaccine hesitancy is one of the major concerns. So if we track, why is it that we have a public health system which is so inadequate, and why do we then have something like vaccine hesitancy at a time everybody is going to be concerned about their survival in the pandemic? I think we need to look at how we have converted the whole broad idea of public health as a science and art and the various determinants of social determinants of health into a very narrow understanding of healthcare, which is medical services. Even today, we've largely focused on COVID. Clearly see the whole imagery of healthcare has been hospitals, ventilators, ICUs, and vaccination, all of which this is medical technology based services. And that's what our imagination has become today. Healthcare has got equated with medical care. And I'd like to show how it's happened because of the model of development that we, with all good intention, adopted at the beginning of planned development and independence, with what those who followed health system development in the country would know was the Bhore Committee report, which was very, very comprehensive, which set us on a path to developing free public health services with the notion of everybody having the right to medical care and healthcare in the broader sense of the term, and thereby that it must be freely available, provided by the state, and the rural area and the tiller of the soil, I'm literally quoting from that report, must be the center point of all this provisioning of healthcare. So this was an excellent beginning. But if we now, with hindsight, go back to it, we can also see that it has all the seeds of actually being operationalized as a very medical service. For example, just as one instance, it insisted that the good MBBS doctor had to be the base of everything. The licentiate 3-year trained doctor, which provided 2/3 in number, they were 2/3 at the time of independence in the country, providing medical care in communities, were not to be officially recognized at all. Therefore, it's only the 1/3 doctors that are left to be hired by public service. The traditional systems of medicine and any other than modern medicine is not to be considered as part of the blueprint of healthcare for this country. This put aside a whole lot of healthcare that was available, and therefore the public system and public health was structured around modern medical science and the best doctor and the hospital that goes with it. Even the primary health center envisaged in the Bhore Committee report has at least 6 doctors, a large number of beds, and 75 staff in all. That's something that even our district hospitals don't yet have. And then there was the district hospital, which was secondary care, and then the medical college. Therefore, we start with a blueprint in the name of public health. And the report also talks about town planning, country planning, habitat planning, occupational health. So it has all the making of social determinants of health in it very, very centrally. But yet, because it posits its full faith in the doctor and the hospital, my argument is that that set the tone for the rest of development of healthcare in the country, and therefore did not allow public health to actually get operationalized. This meant that to have even a primary health center, you had to have doctors produced. Therefore, you had to, by an imperative of first produce more medical colleges. And therefore, if your budget goes into medical colleges, which are everybody can imagine their expense, and in JNU today, we are grappling with that issue as well. There is the fact of the a large part of the budget and whole attention in the 50s and 60s going to setting up medical colleges. The primary health centers are devoid of doctors, etc., because we are yet producing them. And therefore their quality is poor, etc. The medical colleges, their curriculum, their content has to be the best in the world, match internationally, and therefore comes from the international curricula of medical care. Those produced, therefore, in something like AIIMS. AIIMS has a budget of more 4 to 7% of the entire country's health budget. And that's the kind of order of institutional building up that we did. And now we are building all the extra AIIMS and so on, which need to be built. I am not questioning their need, but the prioritization and the imagery that goes with it, that becomes the image of healthcare. And therefore, our doctors are who had to have merit, be the best doctors, therefore were often urban, middle class, English speaking, and therefore who goes into the rural areas and does medical care. Their sites and their training is much better suited to their going abroad. Or they don't find that the infrastructure in the public institutions adequate for them to provide services with satisfaction to themselves and the science they've learned. And therefore, private care becomes the default option for the doctors that we are producing in our medical colleges, rather than they're going into public health. Now, I'm taking a little bit of time on this because I think this has to be centrally understood for the rest of the path of what happened. In the 90s, when we start privatization as a policy, we didn't need to actually change the policy environment. Even without that, we were already a very privatized system because the doctors had started their own private sector because the public sector didn't have vacancies for them. They didn't have the posts. And therefore, when you have a private sector lobby, that's a lobby which lobbies for its interests. And that pressure is enough for privatization as a policy. Of course, then it got all the support from the international and globalized policy frameworks and so on. So this trajectory then brings us to the point where the medical industrial complex and the corporate sector comes in very centrally now with managed care, with the Apollos and all the other chains of corporate hospitals, and they become the major image of what is a good hospital. Till the 80s, All India Institute and district hospitals provide an image of what is a good hospital, and even the middle class would go there and would want at least opinion of the doctors of those hospitals. Today, that leadership has shifted very, very completely. In the last 30 decades, in the last 3 decades, 30 years, that is something that we are clearly seeing. And today we now have Ayushman Bharat, and now we have the ministry putting out 100% FDI for investment in healthcare, with the idea that that is what is going to be private healthcare. And the National Health Authority, which overlooks Ayushman Bharat, will overlook the National Health Digital Mission, and is now helping states do public-private partnership for giving their public hospitals into private hands. This is very parallel to the monetization efforts that we are now seeing, it seems to me. But that's clearly where we have now moved from Bore Committee to this, is a long leap, and clearly Bore Committee kind of options were what were closer to an understanding of public health and right to health care and equity in healthcare services and so on. But it, like as I tried to demonstrate, it had the seeds of this medicalization inherent in it. Today, we are also now talking of the mid-level practitioner, which was close to the licentiate, where nurses or IU providers would begin bridge training of 6 months and become the lead persons in the health and wellness centers. And therefore, it seems to be a kind of going back on what Bore had done, saying only the best doctor, and you're trying to produce substitute doctors of this nature. So that's on that side of it. Very quickly on what has been the response of People's Health Movement or community responses to COVID and over these years to the kind of decline in public health and medical care. The large response of the health movement has been in right to health, as Priyanka laid out very well, and thereby in access to, adding the term quality, access to quality care. But how do we define quality care? Will it include people's knowledge, what people can do themselves? Is that part of what quality care and services will do? Therefore, where does that fall in this are still very open questions. And we've seen during the COVID, the kind of resistance to any kind of integrative or looking at other systems and epistemologies coming from the IMA. And there is some value in that also in the way it comes when it comes in a commercialized mode with Patanjali and others being the forerunners, being seen as the forerunners of. But there is a Ministry of Ayush, and there's a whole stream of people in the let me call it the traditional medicine stream of both civil society, private practice, and the public system, who have invested several decades in highlighting the value of what they are able to provide as complementary alternative medicine and as full medicine, but with different epistemology, a different way of understanding health problems and dealing with them. This is an issue that I won't go into further, but I think it's a very central part of the politics of knowledge for public health and designing our health systems in India. This kind of issues were being taken up in the 70s and 80s by the People's Health Movement, of primary health care, of how to operationalize it on the ground, what are people's issues, what are workers' issues, and so on. And it is the 90s which seemed to derail that, because the issue of access, of trying to protect what people had been able to gain through democratic processes and the building up of a public health system network, just protecting that became an issue for the 90s. And therefore, politics of access and right to health became the focal point of People's Health Movement. And the politics of knowledge got sidelined. And I think today we are again at a juncture where politics of knowledge has become very, very central. The COVID has brought it on with, and that's where I'd link it to the vaccine hesitancy. That hesitancy is not only because of obscurantist views or the social media saying it is to make us impotent, it will sterilize people, and so forth. One kind of fear being generated by the social media. But putting that aside, there seem to be very genuine bases for why there is hesitancy. And I'd like to take us a bit through that, just to as an illustration of what depths we need to get into for addressing and being able to take on politics of knowledge. If we take vaccine as a very central preventive measure in COVID, and I, as a public health person, do consider it as important with all the evidence we have. It is important for decreasing the number of cases, of severe cases, and of deaths. And that's a central issue. As of now, with the large number of deaths that we have, preventing any proportion of those deaths is extremely central. Therefore, I would go along with the fact that vaccine is an important component. But just as Anant said, that medical care is one part of healthcare, the vaccine can only be one part of our preventive measures, and I'll try and explain why, and thereby also the kind of politics of knowledge that we need to engage with. The point of the vaccine is to enhance immunity, and to enhance immunity to a level of what we understand as herd immunity, that is that more than a certain percentage of people, proportion in the population, become immune to the infection, so that then it cuts the cycle of transmission. If there are two people who can get infected, but the third cannot, the movement stops at that point. And that's where, it's like there's an ad that we see of, a plywood which is fire safe, and it protects from fire. So you have these number of logs which pick the fire, but then when they come to that one, that acts as a barrier. So that's how an immune person acts as a barrier to the spread. And if you have enough of them, today it's earlier it was thought it could be 60 to 70% for COVID. Now with the variants that we have, it seems to have become 80 to almost 90%. People need to be immune to have enough herd immunity so that the rest 10% will also not get the infection. Now, this is what we expect the vaccine to do. The vaccine we now have is not seeming to protect from infection spreading too much. It has about 40% or 33% with the new variants now, possibility of protecting people from infection. But it does seem to, all epidemiological evidence does point to the fact that it is preventing the move from mild disease to moderate and severe disease, and from severe disease to death. So if the vaccine does that, it's still protecting me from becoming seriously ill. Now, therefore, is this the only option? Is this the panacea to protect us from death due to COVID? I would argue that we have very clearly alternative ways in which, as a collective, we could have dealt with and protected ourselves while keeping the vaccine as one of the many measures that we would adopt. Of course, these are, but the debate really is, do we believe that there is natural immunity to COVID or not? And do we believe that it has meaning in developing herd immunity? This has become central to the discussion right now because the vaccines, which are not yet fully tested for their efficacy and safety, are being applied to millions and millions of people with the argument that we don't have any treatment and therefore anything that prevents the deaths needs to be used. But do we not have any treatment, and do we have no other protection? Innate immunity, like I said, means that there are two kinds of innate immunity, again, briefly to go into the biology of it. Innate immunity, which protects from any infectious agent that will come into my body without any specific exposure earlier. That's an innate immunity that all of us have. The ones who have low immunity because of malnutrition or other diseases or taking other treatment may be outside that. Other than that, we all have that in him. There's also building of innate immunity as we get exposed. And that natural exposure itself is immunity. And we've seen that through our serum in India have got immunity while our vaccination rates are much, much lower. So that exposure and that natural immunity has developed in large part of the Indians. Now, if that is so, then what is the role of vaccination remains a question mark. There's a whole debate and contestation across epidemiologists and immunologists on this, and it's a question wide open right now, as far as I'm concerned. The active enhancement that vaccines do is very useful in a point like this where large numbers are involved and we want to prevent their having to get hospitalized and further on. At the same time, this is the time when there is an argument that with higher pressure of vaccines, you'll have vaccine escape, and therefore more variants get created because of the vaccines being applied on a large scale. This again, as I said, it remains another open question as of today. The other possibility of decreasing numbers needing hospitalization and death is that you're able to, as Anant pointed out, do monitoring in early stages, provide treatment in terms of steroids and maybe small amount and a few hours of oxygen in the second phase, in the 5th to 10th day kind of phase, and that would allow people to recover. So at the moment, the important point is also that 80% of those who get infected, at least 80%, either remain asymptomatic or have mild disease, and therefore stop at this point of 5 to 7 days itself, at the most going to some bit of moderate. So it's 10 to 15% of persons who get infected. But let's say that we expect almost everybody to get infected. So that's 10 to 15% of people on this globe, and that's huge numbers. That they would get infected, can we, through this regimen that Anant pointed out, decrease that 15% that would be in this phase to, let's say, 5%? The next 10%, if they could be catered to with this initial treatment of monitoring and giving steroids and oxygen as and when required, then that 5% is equivalent to what, even with everybody vaccinated, we would still expect would go into a serious phase and require hospitalization. So the issue is, do we have capacity or capability to shift through initial treatment from 80% to, or 85% getting mild disease to 95% getting mild disease and getting cured after that? That seems to be, from a public health, primary healthcare perspective, completely possible. If we have a primary healthcare system, or we gear it up enough with volunteers in a crisis phase like this to actually provide this kind of care, then vaccines and the safety issues and safety concerns that go with vaccines could be minimized. The second concern with vaccines in this kind of a phase, and the experience of influenza shows us that, in the last 50 years, that vaccines in a disease of this kind will mean that we get onto a treadmill of, forever and ever, all of human civilization always producing and giving itself the COVID vaccine. Because anytime you then stop it, you are likely to get explosive outbreaks because you won't have natural immunity. Therefore, there are then ways and arguments that can be made that from a public health angle, can we think of, in the long term, after the COVID pandemic is over, how can we get off the treadmill? Can we? That is not in the imagination at all as of now, because that's not been the experience of any other disease before. Influenza shows us that despite the vaccine, in the US, we still have, I'll just take 2 minutes and close. We still have, something like, they have 30,000 deaths every year, despite vaccines, despite a very strong, mechanism of updating their vaccines with the variant changes and so on and so forth. So that seems to be the future we are looking at with the coronavirus. And to me, that's because we are not looking at the option of primary health care and provisioning of care as an option at all. We've all been completely, let me say, psyched into one imagination of a coronavirus disease which is novel, for which we don't have innate immunity, and therefore the vaccine is our panacea and savior. If we can get off that, to me, that's politics of knowledge. And the other dimension is that if you believe in innate immunity, then strengthening innate immunity is what traditional medicines all are geared towards in dealing with infectious disease and with epidemics. And therefore, then you can start seeing them as another possible avenue of strengthening immune systems at a societal level. So, this whole issue of immunity is central today to politics of knowledge. Therefore, I thought I'd highlight it, and thereby end by saying that what my argument is basically that unless we go back to our politics of knowledge and its alternatives that it provides us, the politics of access, ensuring right to healthcare, is not affordable. The Bhore Committee had expected that 15% of all of Government of India budget would go to health, and only then could its blueprint be operationalized. They actually discussed that should we give an ideal blueprint or should we give an operational feasible blueprint, and they decided on an ideal blueprint. Obviously, the real world is not ideal, and therefore, how do we make these options and priorities for ourselves is the question, and the politics of knowledge. Thanks.
Thanks very much. With all the three in the panel, we have a very panoramic view of the problem, from health as a right to the actual concrete issues in the health system, public health system, and concluding with issues around vaccination, raising fundamental questions. So I invite Sayan Das to discuss these papers and bring things into perspective, and then we will open the floor to discussion. Yes. Sayan Das. You're muted. Yes, no. Yes.
I'm audible. Okay. No, just saying, like, thank you, Chair, and thank you, the colloquium, for this opportunity. And thank you, the speakers, for your illustrative deliberations on this issue of crisis in public health, especially during this time of COVID pandemic. All the speakers have sort of focused on different aspects of the crisis in public health right now. Like Anant has focused on the micro aspects of the health system, the healthcare delivery itself, how it's mismanaged, how it's malnourished, and how it has happened because of less of public expenditure into healthcare, the rural and urban disparities that exist. Moving on to Priyanka looks at it from the perspective of right to health, and how right to health is not a fundamental right still enshrined in our constitution. And she has talked about the different complexities, therefore, which are there in terms of looking at or talking about right to health. She looks at a Rawlsian perspective. She brings in Amartya Sen's capability approach. And then moving on to how, therefore, leaving aside the particulars, but having a more general kind of a framework of right to health is the need of the hour, as she proposes. Then I would come to what Anant sir said in his presentation about what he defined as a crisis. He said that it's inability to function in a quote unquote normal way. I think then the question becomes like, even before the pandemic, did the health system function in a normal way, even during a so-called normal situation? So I think this is where Professor Ritu Priya comes in, and she sort of tries to understand and traces historically how health systems have developed in India, and how, like, during the colonial times and just after independence, with the Hore Committee report, which gave a very idealized understanding or idealized blueprint for a health system, which never materialized, of course. And then over the times, how the seed was then sown, which later on was exploited by the privatization and the corporatization to actually come to where we are today, in a public health system which is underfunded, mismanaged, and private care which is very rapacious in its nature, which is always looking at the profit motive, like even during this time. And the kind of public health policy that we see, like Ayushman Bharat, for instance, which was launched with much fanfare, was ineffective during this period of COVID crisis. So therefore, it brings to question, like, what kind of public policies or public health policies which are also coming in view of the pandemic that we have right now. Another thing that I want to draw attention to, which is perhaps not as much discussed, is like, since this is a creative theory colloquium, so I was just thinking, and since the chair also spoke about a polyphony of expertise and various kind of information explosions happening, so we need a perspective to actually traverse through all this. So I also was thinking of a theory. So is the public in public health, is it theorized enough, given the kind of instances that we see during the public pandemic? Mostly in public health, public is seen, like, depending on the version of public health that we have, like the very state provision public health, which is very command and obey kind of a public health, as Anant Phadke said. So there, the people is looked as a problem, which needs to be controlled and managed, right? And then there's a laissez-faire kind of an approach to public health, which looks at people as free agents who have to make their choices, free choices that they make, and the resources are just there, and they just make the choices. But then the kind of instances that we saw during the pandemic, when the state was failing, where the various institutions, government or private institutions which were there to provide services were failing, people actually took things into their own hands. Like if you look at various kind of community initiatives which came up during the pandemic, not only in India, like across the world. So this is something that I have tracked and have sort of mapped, and there have been various instances, like people not only sharing information, they are providing social protection measures, they are helping people with community tracing of contacts and helping people who are the sick. Then there have been instances where, like in Satara in Madhya Pradesh, where the farmers, because of the lockdown and their whole farming chain becoming disrupted, they initiated a direct contact or connect with the consumers themselves, and they eliminated the middleman in the process. So they found a market for their own supplies at the same time, and the urban component or the counterpart actually had the nutrition that they required during the pandemic. So various kind of innovative solutions actually came up. In South Africa, there was this campaign which was called Outbreak of Solidarity. So instead of looking at the outbreak only as something which needs to be feared, they talked about various tools and various ideas that people can implement to help the community or help those in need. And by here, like, we're not trying to romanticize community. Of course, we have also seen the kind of stigma or ostracism that was faced by the migrant workers, or say the ASHA workers who were doing house-to-house surveys. They were often ostracized by their community. So those things are already there. But the community itself, again, like, there's this instance of COVID care network which was formed in West Bengal, where doctors as well as people who suffered from COVID themselves, who were COVID survivors, they came together to form this network, and they used telemedicine, they used awareness approaches to go to different localities and to make people aware of the issue, and also to reduce social stigma around the infection. Not only that, like, in so various aspects, like Kudumbashree, the community kitchen that it ran in Kerala, the Snehita gender desk that Kudumbashree operates, it actually had small shelters like in every district of Kerala, where they were actually helping women and children who were suffering from domestic abuse, which actually rose exponentially during the pandemic. This is a silent pandemic that very few talk about. So this is what happened during the pandemic as well. So interestingly, if you look at the gamut of community initiatives which came out during this pandemic, it actually goes beyond just healthcare. It goes beyond just health systems. It's actually looking at various aspects of social life which were disrupted during the pandemic and which needed to be taken care of. So therefore, it also gives an alternative imagination of public health, which is just beyond health system or just beyond the health care services that we have, or which is the mainstream way of looking at it. So I was just wondering, like, is then therefore a need to look at public health theory again to see how the relationship between state, society, market, and communities work, and how we do need to, like, do we need to recast it? Do we need to reconfigure it given the light of the pandemic right here? So I'll probably conclude with this question, probably for the respondents and the participants in this colloquium to probably ponder over it or maybe respond. Thank you.
Thanks, Sandas. What you're proposing is the job of a sociology of health and medicine, which has to take public health and politics into account. I'll come to it in the end during the summarizing round. But now we open the floor to questions, and we have some 15 minutes, 15 to 20 minutes. You could either type the questions or ask them verbally. Please feel free. Yes, Neelam. Yes, please. Yes, Neelam, you want to ask a question? Please unmute yourself.
He's written the question.
Okay.
Survesh,
Yes, yes. I will.
What would
Thank
be
you,
the...
all three of you, for making it a really, really insightful session. A question for Anant sir and Ritu ma'am. One, what would be the future of the public health system in India or healthcare sector transformation in general, in the context where the private healthcare system failed to cater to COVID emergencies, but also at the same time we have seen a massive surge in profit among private health companies, the rise of medical startups as a money-making industry, and also the rise of healthcare. And the second question is, rural areas, especially the tribal inhabited regions, saw substantially lower COVID fatalities despite the inaccessibility of a robust public health system, giving rise to a multiple hypotheses. I also witnessed this phenomena in rural areas. One of the hypotheses was, of course, the far locatedness of tribals and better and natural social distancing. But beyond that, there were few digestible hypotheses. The first was that rural tribal people had better immune system due to healthy food habits.
Yes. Should we take the answers to these questions and then move to the other questions rather than collecting them? Do you have any suggestions?
Ma'am, I think we should collect all the questions first.
Collect all the questions. Yes. Okay. Yes, please. Please raise the question.
Neelam has another question as well. Survesh, can you please read?
Yes. The second one was that tribal was better immune to bacterial infection due to their extensive microbial load and general exposure to a variety of pathogens as they live in close contact with nature. I was just curious to know the understanding among the wider medical fraternity.
Yes. Manindra?
Yeah, yes. Small query actually. I was just wondering the data about COVID cases and about the kinds of problems the patients faced actually during that time, seems to be limited to their days when they were actually consuming medicines. And after that, say, COVID is a kind of thing which has long impact, it seems, what they call long COVID. In fact, there's a longer impact than that, which means that there are serious issues related to orientation disorder. Do you think those kinds of data also being collected, or is there any research being done on this kind of longer impact of COVID on overall well-being and other kinds of health issues? I just want to know. I don't have any idea about it.
There is one question on the chat box. I'm reading it out. How can we understand the long-standing over 75 years of low investment in health sector by the different governments?
Yeah, low investment in health for different governments. Why is that he wants to understand? How do we understand that, irrespective of regimes? Any other questions?
Yeah. Vidyut has a question. Yes.
Yes, please.
Yeah, Ritu, do you remember me?
Of course.
Yes. Now, I have a specific question to you. Does Panchayat have any role in tackling the health issues in the context of COVID? Nobody talked about that. Can you elaborate on this? You gave a keynote address in my Women's Empowerment Day, and your article is still here.
Okay. There is another small query. Sayan has talked about this redefining the idea of the community health or the relationship between state, society, market, and healthcare. Can you just elaborate upon it? What kind of new horizon is needed on the health, the new perspective one can think of on the health? And one thing that I can understand from Priyanka's argument, and as Manoj Jha has been talking about, right to health, like right to education. But that is within the larger similar framework of liberal perspective. Is there something new that we can think of in terms of perspective on health, which is different than this modern understanding of health, either supported by the state or by the market? These are two options we have. Is there something more than that you're suggesting?
There is one more question on the chat box.
Yes.
What should be the policy response of the state to boost equitable immunity?
I also have a question. Yeah.
Yes, Professor Mohanty, please.
I mean, it's a wonderful session, very rich. You know, on the education sector, the
NGOs and the people's education initiatives and movements have a more substantial presence in society. Whereas the 70s and 80s picture of the people's health movement seems to have either got localized and specialized or have disappeared, completely weakened. And is that because the people's education movement has now been differentiated and part of it has become professionalized and funded and even linked to international agencies? So what is the experience with the people's health movement? Because that will determine how we shape our movement for right to health. For example, the forest rights movement or the education rights movement, acquired a certain momentum leading to the act and all. I mean, there is a right to act draft at some point, which was circulated during the UPA 2. It is there. That's all. Now, so what explains this? Because that will determine how all the three dimensions, the social determinants, that is, comprehensive notion of health, and the people's knowledge dimension, all those things, and matching the challenges that capitalism and technology pose while they appropriate the leadership and all initiatives of health. So that will determine. So what explains the current state of people's health movement? That's my question to the whole panel.
Can we stop here for the first round? Because I think there are 10 questions. Can we stop here for the first round? There are 10 questions. So let's discuss those.
Yes.
Then go on to the next round.
We can't hear you, Professor.
He suggests that we stop at this moment and.
That is what I will also just. We have a good number of important questions. We can take them. I would just like to join Professor Mohanty. I had the same question. Something that I observed, that whereas education, livelihood, land, reservations all seems to trigger movements, huge deficiencies in health, even they don't seem to trigger a public movement or a mass movement. Rather, people get angry, beat up doctors, those kind of immediate expression of anger and frustration you can see throughout the country. It's been happening all the time when they face a loss. But there is no the movements are not being strengthened despite huge gaps in the public health. So I would like to listen to your responses, though as a sociologist, I have my own response to this question. So shall we take in the same sequence Priyanka, Dr. Phadke and Professor Ritu, Priya to please respond to the questions? Priyanka, would you like to come in?
So since the questions have not been directed specifically to anybody, I would rather take Mohanty sir's question and Manindra Thakur sir's question together and give an answer to that particular part. So both and also the Sujatha ma'am's query. So I begin with what Manindra Thakur sir said, that what is the kind of model that we need to adopt in the crisis scenario that we are facing today, and in the neoliberal world order. So I believe now is the time to go back. I think now is the time to go back to what Bore Committee report had said. We need to strengthen health infrastructure, which is in crisis today. So the Bore Committee report suggested primary care, secondary care, and tertiary care, a specific medium of a specific provision for healthcare services to be delivered in a particular manner in which every access to healthcare services is irrespective of caste, class, and other social determinants. So this kind of an infrastructure would then facilitate healthcare and not make it a commodity. Even today, if you look at it in the capitalist system, you have clinics, you have private clinics, you have then hospitals. So in a way, in the capitalist sense, also you have the similar kind of a model, but private entities are running it with a different ideology. They are running it with the ideology that it is something of value. It is an economic good. So I want to say that no, we need to go back. We need to understand and need to begin the thought process that this is not economics. This is a right. We need to understand it in the Lockean term that this is a right, and we have to deal with this subject as a right. And for that, Bore committee did give a very brilliant recommendation, which was never considered. The kind of models to be adopted, the kind of health infrastructure for communities. So this is one thing. This is the answer that I would give for Thakur sir's question. Coming to Mohanty sir and me, Sujatha ma'am's question, then why people's movement, health movements are not strengthening. Again, the answer starts from the ideological perspective that the sense among masses since the very beginning is that health is an economic good. The more money you have, the more good services you could buy. The more richer you are, therefore you see, whenever a particular class of people, a mass gets social mobility or gets to climb up the ladder, the first thing that person buys is an insurance, a health insurance, or maybe some other facility. Who has a person who has more economic capacity can avail a particular kind of health services which comes at a price, but a person who cannot buy has to then rely on the state. And we are very aware of what is the kind of state, what is the kind of condition, what is the condition of the state health infrastructure. And why the movement is not strengthening? Because you have options. The market has created economic options. And health is a very sensitive subject. People will not wait for it. Education is also a sensitive subject, but one can still wait for it. Just imagine if there's an emergency, a person will never wait for the state infrastructure to function properly and have everything and etc etc. No, they will straight away do what is required. Usi samay pe you will get the best possible services available under your radius, or maybe also arrange strengthen yourself economically for that. In fact, so therefore, this kind of heterogeneity amongst the masses in the ideological perspective, I think weakens the people's health movement, and therefore you do not see a health movement as well. I'll give you an example. In the COVID period only, you faced oxygen crisis. Everybody was facing oxygen crisis. There were problems of hospital beds. There were problem of medicines. There were hoarding happening. People hoarded medicine. Who could hoard medicine? They buy and hoard medicine. People booked up beds who had the capacity to do it. People hoarded small oxygen cylinders at their home who could do it. So nobody in a crisis scenario or in a health emergency situation, nobody thinks of the other. It's only about the self. So, and when you talk about a movement, it is always the other and people together, but then it works, and then therefore the movement strengthens. So here the scenario is very different. Health is when it comes to health emergency or a crisis scenario, nobody will I don't think so anybody will wait for a particular juncture to come and speak therefore. So I think I have answered. We can move ahead.
Thank you, Priyanka. Dr. Phadke, would you like to respond?
Yeah, very briefly, 10 questions. Basically, the first question is about what happened to what is the future for healthcare in India if this privatization and commercialization continues. So, in one single word, disaster, nothing else than disaster. I'm going to be very brief. Only things which require some explanation I would rather give. Then was one point made about COVID fatality rate is low in rural and tribal area. I'm sorry, whatever I have read, I have not seen any such evidence. These are impressions, but they need to be confirmed on the basis of some solid data, which is a difficult task. All that I can say, if you see the basic epidemiology, that those people who have less social interaction are less likely to get infection. And if this less social interaction and therefore less infection rate remains low for coming few months, also by the time we reach herd immunity, then the infection rate will be low and therefore the fatality rate will be low. But if you see infection fatality rate, I don't see any ground for saying, no evidence I have seen, maybe I'm not so well read, that any such thing happens. There is any such basis to say that rural people or tribal people have more immunity to COVID or any such thing because they are closer to whatever, some microbial thing or nature, etc., etc. I don't think that, to my understanding, this is not true. And at least I have not seen any evidence, and I don't see a logic behind it also. There was one talk about long COVID. Yes, about 20 to 30% of people who get COVID, symptomatic COVID, not infections, symptomatic COVID, they do have long COVID, which can go from weeks to months. Fortunately, most of these cases resolve on their own without any medical treatment. Even lung fibrosis, which is one of the most sinister of complications, the patient seems to have not worsened and they improve gradually. So and therefore those people who say कि COVID कुछ नहीं है sir, simple cold, some minor viral infections, everybody becomes all right. Yes, we have been saying 1,000 times that please don't be scared. Most COVID patient infections are all that we are saying. But at the same time, of all the symptomatics, which are millions and millions, 20 to 30% also have continued to have some problems for some weeks to some months. And therefore, I am one of those strong advocates of vaccination. We have fought for 40 years against useless vaccination, questionable vaccination, but I am one of those who are very strongly advocate of vaccination, despite dismal track record by the Indian government on various fronts. Low investment, I think this is a good question socio-politically. What is the reason for low investment? I think those who are sociologists would say that basically it's in a sense, I don't want to reduce everything to politics, but yes, it is basically a function of the balance of forces between the ruling class and the toiling people. After independence, when there was a strong pressure of the people's movement, of the independence movement, the new ruling elite, the Nehruvian elite, was responsive, was under pressure of the aspirations of the people. Their own ideology was also that of welfare capitalism, and therefore the investment increased 0.5% of GDP gradually to 0.8% of the GDP. But with the new order, where capitalism became more aggressive and basically the state capitalism receded to a certain extent with the neoliberalism, gradually the investment became low. Even within that also, if you see, there was a decline from 1.3% to 9.9% till 2004. And because of the 2004 elections, where the Congress came into power after UPA won, with some pressure from the left and democratic forces within the government, NRHM came, National Rural Health Mission, and the investment also increased from 0.9% back to 1.1%, very, very low. So basically, it is because of low pressure from the toiling people. But we should also understand that the rich people and the capitalist people also want, it is their vested interest to have people healthy so that they can work harder and give them more profits. So there is this contradictory need. On one hand, you want people to work more, and therefore you want them to be healthy, and therefore you are ready to spend some money. But so long as you can get a cheap labor, that is what happening in India, and people retire prematurely, they die away, they go away from the scene. You can afford to have those kinds of people. So long as poor people keep replacing within the labor force, I think the capitalists would rather pay low taxes and have low quality public health services. That's my overall understanding. I think it's probably a classical understanding. State society health, I think Priyanka had said something on his own way. I don't want to get into that. There is a question of what can be the policy response for the state to boost immunity. I don't think anything such can, there is no such policy to boost immunity. For COVID, I'm saying, but for in general, of course, everybody knows that better food, nutrition, better environment, all that contributes to better immunity. And therefore, all that we have been talking about improvement in social determinants of health is something that can be a possible response by pro-people government. But this new government is more anti-people than the previous one, and therefore, at least I don't have any hopes about it unless we guys sort of put more pressure on that. There was this last point about health movement has reduced, etc., etc. Unfortunately, I don't agree with it. I'm one of the sufferers. I've given my entire life for last 40 years for public health movement in India. It has not certainly advanced as much as we all thought it should, especially after the birth of Janaswasthya Abhiyan. From 1980 to 2000, we were in medical friend circle, all kinds of small group, Lok Vigyan Sangatna, but health was not a common agenda for many groups. 2000, we came together at Janaswasthya Abhiyan and launched something, and we thought that we had a very elaborate discussions. I do think that we have come out with a very good overall perspective and program, demands, etc., etc. We continue to be active, but we certainly have not become the kind of force that we wanted to be. NGOization is something which has really contributed to this kind of a lull. NGOization has its own contribution in terms of contributory contributions, but yes, it is not has not sort of improved, has not been strengthened as much as we had all thought to be, and we really need to step back and think why this is happening. But I certainly don't agree that compared to 1970s and 1980s, that the health movement has declined. I think on the whole, because of neoliberalism, because of collapse of Soviet Union, because of people's experience about left-wing governments in Bengal, especially, I think the overall support for progressive politics has also somewhat waned. Primarily, of course, is the neoliberal policies, which is there all over the world. So that is an overall decline, or I would say overall failure in terms of the expectation that we all had about the people's movements. Because I think the problems have also become very complicated also. Just last point. Yes. See, in Bore committee's time, there was no question of gender-based violence was not considered an issue at all, not mentioned at all, which was an important issue which has been taken up now, which is very important. Or the world has changed a lot. Like we have 100,000 traffic accident deaths in India, 100,000. The far more than most infectious diseases except tuberculosis. Now, this is a new phenomenon of unsafe road transport. So all those new social determinants of health have come, which have worsened. Some of them have made some other impact also. So I think it's a more complex situation, and keep referring to Bore committee only, I think is something which will not help us a great deal. Thank you.
Yeah, Dr. Dr. Ritu, Priya, want to respond to some questions?
I mean, there is shortage of time. I'll quickly want to look at some of them and link them. The future of healthcare post-COVID. From what has happened during the COVID and what the policies seem to continue to be, we seem to be, as Anant says, moving towards further disaster. The healthcare becoming more difficult for people to access, becoming more medicalized and over-medicalizing, and therefore more iatrogenic, etc. And therefore, I would think that the way the Ayushman Bharat and Wellness Center kind of model is being put forward, there would be so much public-private partnership as part of it that access would become an issue, while we may continue to have a large network of health care in the country. And therefore, I would think that communities would have to develop their own ways. And I link this to the fact of why there isn't a popular people's health movement, in the streets. Why does it not become an issue when it's an issue of survival? Whatever the studies we have on health-seeking behavior, on people's perceptions on health, there are very complex understandings of health in our communities and laypersons' minds, coming from their understanding of how the social determinants affect their lives. They understand how living conditions, food, healthcare, work, etc. affects people's health, and they need healthcare only in a crisis. So it's almost as if, if you have a problem with your plumbing, you call in a plumber when you need it. You don't constantly have something dealing with that. So it's almost as if this at that time you need. So this view of health they're not looking at how they understand. Their understandings are close to public health understanding than medical understanding. But we don't bring it together because the public health understanding comes from the modern biomedical frame, and their understanding comes from the traditional knowledge in which they are socialized and part of their cultures. And therefore, the two don't match, and we seem to think they don't have a cultural understanding. So one is that, and therefore there is a lot of resort to preventive health, preventive care, and preventive practices. But they're in their own vein. They're not necessarily in the vein of modern public health. So how do we bring these together and create a more holistic understanding for our own society is, I think, one of the ways forward. And that's why I call it politics of knowledge in that sphere. It's also about the state markets. It brings in the whole issue of state market, community, and the professional relation. That could be separate. The professional could be in the public sector, could be in the private sector, but also has an autonomy of its own. The IMA comes on not only as a private doctor's interests, it's also about the science and how they would want to be viewed in society. So that's an issue which comes in with professional interests and so on, and becomes a larger frame. But somewhere we'd have to therefore, again look at politics of knowledge, which tells us what is it that we want our public sector to be delivering. And since health, the buck eventually stops with me about what I will do. Will I take the shot or not? Do I want to take the medicine the doctor gave me or not? So what as doctors, we look at defaulting patients who don't listen to what we say, is about the fact that I'm exercising my choice as an individual of whether I want to take what you prescribed or didn't. And therefore, if that, so that is the bottom line. And yet, health is not only an individual phenomenon, it is with social determinants and a collective phenomenon. And healthcare is also collective, whether it's you see it as a culture or you see it as science, it's a collective phenomenon. So, moving across these is certainly sociology, as you said, but it's very central to public health. Role of panchayats, Vidyuti wanted to talk about, and Anant did refer to it briefly. But certainly, again, when we come to the interface between state and community, the panchayat should become very central in that role. But there have been instances where after the 73rd, 74th Amendment, where states tried to put the local health services under the panchayats, and the doctors, that's why I said the professional interest would not take it. They don't want to be subservient to the less educated Zilla Panchayat members and the Sarpanch and so on. And therefore, again, it's politics of governance as well as politics of knowledge coming together. The doctors have to recognize that they have expertise and knowledge of one kind, and other sectors of society, other people have their own. And that's when the doctor-patient relationship will also become more democratic. So, there are all these various layers that need to be looked at much more.
Thank you very much, Professor Ritu, Priya, all the panelists. We can take one question. Dr. Savita Singh.
Yes, ma'am. I will read
your
it
question.
out.
Yes.
Why do you think even a deadly corona pandemic has not affected the legitimacy of the state to continuing the same attitude towards healthcare?
I think our time is almost over. So you have to.
No, this is in connection to the previous question also. Why such a huge pandemic has still not drawn attention of the state, and why subsequent regimes have. Can you be brief?
Very briefly, I'll answer this question. I would rather make a statement on this, that why the corona pandemic has not affected the legitimacy of this state. This is a question of further interrogation and needs more research on it. However, it has drawn political attention. The pandemic has affected political minds, and the question of how health, the subject has to be dealt with, is becoming political, post the pandemic or in the ongoing pandemic period. So this is what I would say for this question.
Okay. So there's one question on self-care and its importance. I think Professor Priya's response about traditional knowledge and all those will make would have answered that question. Now it's time. I mean, this discussion can go on and on. I'm sure the experts in the panel will be open to discussing this outside the webinar as well. It's raised many questions. So we should, it was a very nice discussion. I was very happy to meet Professor Mohanty after such a long time. I just will very quickly want to, I can't, close without saying this one little remark by the discussant saying that you should open up the notion of public. Okay, but in common parlance, public health refers, there seems to be a confluence of public and society in the way you put it. When we say public health, it refers to the government health services and its connection to the community, etc. That's a standard sense in which it is used. But today we have civil society, NGOs, etc., fighting for the rights of people, actively involved, Jan Swasthya Abhiyan. Then you have what you mean by society is the neighborhoods, kin groups, families, friendship groups, virtual communities like WhatsApp, Facebook, and all kinds of loose associations. So they come what I would call society and so on. So public health in the standard discussion has looked at government health services and its interface with society and community is what. Now, but it's high time we looked at the role of NGOs and other associations, especially in the context of the pandemic. They've always been there, but they have gained greater visibility now. And one of the reasons why the pandemic health is not such a central political issue, in my view, is that people view ailments, bodily happenings as belonging to the realm of the private, in a way that they don't think of other things like land, livelihood, etc. So that is why it comes under the realm of home remedies, other kinds of knowledge, and only allopathy is seen as a curative mechanism. So I'll stop here, but this, as you can see, this discussion can go in many directions. I thank the Foundation for Creative Theory for giving me this opportunity to listen to this very nice discussion, and best wishes to you.
Thank you. Thank you.
With that, we have come to end of another brilliant session. I would just like to thank Sujatha ji for chairing this session, and also a big thanks to all of our speakers and the discussant for an enriching discussion.
Channel. If you have any questions, comment on the video and don't forget to press the bell icon for future updates.